We are about to start our town hall for this, I guess I'll call it late afternoon. And we're going to give people just a few minutes to join us before we actually start talking to our guest for today. Okay, I think we are ready to get going. People will, as people come in, they can just join us. I want to welcome everyone who is here at the start of this town hall. We're excited to have as our guest Dr. Jason Tye-Din. He is the head of the Celiac Research Lab at the Walter and Eliza Hall Institute of Medical Research in Melbourne. So if you're thinking about it, that's Australia. So while it's the end of the day for us, it's very early for Jason, and we appreciate him starting our day with us. And we'll have Jason introduce himself a bit more thoroughly in just a moment. I'm Amy Ratner. I'm the Director of Scientific Affairs at Beyond Celiac, and I'm joined today by my colleague, Kate Avery. And Kate, you want to do a brief introduction and then throw it to Jason?
Sure. Hi, everyone. Thanks for joining us. I'm Kate Avery. I'm the Senior Director of Coalition and Patient Engagement at Beyond Celiac, and we're really thrilled to have Jason Tye-Din join us today. Jason, do you want to introduce yourself?
Yes, thanks, Kate and Amy. Yes, so I'm an adult gastroenterologist. So I've been looking after people with celiac disease and gluten-related disorders for nearly 25 years now. But I also run a research lab focused on understanding why celiac disease develops and developing better ways to diagnose it and treat it. So I look forward to talking about some of the research projects today with you all.
So Jason's interests and experience and research work is really very broad. We are having him focus on three topics today, one of which is a blood test to diagnose celiac disease. Another is oats in the gluten-free diet. And then the last is testing to determine how well someone is adhering to the diet. And so we're going to begin with a really, I think, really exciting topic, and that is a blood test that can help to diagnose celiac disease and address some of the issues that people have when it comes to diagnosis.
Great. Thanks, Amy. So everyone knows that there's already blood tests to screen for celiac disease. They're the celiac antibody tests. But a big problem with current diagnosis of celiac disease is that you need to be eating gluten for these tests to be accurate. So if a person's gone gluten-free, the blood tests, the celiac serology, are not necessarily accurate in detecting the disease, and you can end up with a false negative result. And we also know that if a person has a positive antibody test, they do generally need to go on to have a gastroscopy and small bowel biopsies to confirm the diagnosis. And this is for the vast majority of people that we still rely on the biopsies of the bowel to confirm celiac disease. As many of you will know, in recent years, there's been a shift towards allowing a small subset of children who have very high transglutaminase levels to be diagnosed with the blood tests alone without the need for a biopsy. But that probably only applies to around a third of children, and that approach hasn't been applied to adults yet. But in both cases, the blood tests and the biopsies require people to be eating gluten for them to be accurate. So we know that celiac disease at its core is caused by these T cells in the body which are targeting gluten. And if you look at someone without celiac disease, they don't actually have those gluten-specific T cells in their bowel or their bloodstream. But if you look at someone with celiac disease, they will have lots of them in their bowel and in their blood, particularly when they're eating gluten. The numbers do reduce when people go gluten-free, and that's why the bowel can heal up. But those T cells are always present, and some studies have shown they can persist for many, many decades. So if we can detect these T cells, then we can say a person has celiac disease. And if they don't, and they're not present, we can exclude celiac. The big issue to date has been there's not been an easy way to detect these gluten-specific T cells, unless you do very sophisticated immune studies on the blood, which often require very large volumes of blood. So it's not been practical. Our recent research has identified that when people with celiac disease consume gluten, within a few hours, usually within about 2 hours, in the bloodstream, there's a peak of a chemical called interleukin-2. This is what's called a cytokine, and it's produced by those gluten-specific T cells in response to the gluten that's just been consumed. And it tends to peak at around 4 hours and then drop down. And interestingly, the degree of elevation of the interleukin-2 corresponds closely with how unwell that person is to the gluten. So if a person is vomiting and having bad diarrhea, the interleukin-2 is very high. If there's sort of a bit of bloating and not too unwell, the value is lower. So it's kind of like a marker for the person's gluten-induced symptoms. But what's really striking is that we've shown that that elevation only occurs in people with celiac disease after they have gluten. If you don't have celiac disease, or if you have non-celiac gluten sensitivity, that value, that interleukin-2, does not go up in the bloodstream. So we've shown that it's a good way to identify who has celiac disease from who doesn't. What we've done more recently is to take this all a step further and shift to everything into a test tube. So instead of asking a person to eat gluten or drink a smoothie made with gluten, we put a blood sample from that person into a test tube, and the test tube contains some gluten fragments, or gluten peptides as we call them. And so in other words, we're kind of doing a gluten challenge in a test tube. And the beauty of that is that person doesn't need to be eating gluten. Now, we're currently conducting a big population study to see how well this test works as a diagnostic for celiac disease. And we've now tested close to, I think, about 85 people with celiac disease and a similar number of people without celiac disease. And it's performing exceptionally well, as good as the transglutaminase assay with, over 90% sensitivity and specificity, which means it's a good way to rule in and rule out celiac disease. This test, the strength of this test is people that we've been testing have been mostly gluten-free, and they have the negative celiac antibodies. So this tells us this test is very, very sensitive to detect the gluten-specific T cell, and it offers a way to make a diagnosis of celiac disease without people needing to eat gluten. And hopefully in the future, if this is taken on more broadly, it may be a way to diagnose celiac disease without needing a gastroscopy at all, which would be fantastic. Now, there are other groups now, including in the US, where we've got collaborators who are adopting this test for use in children as well and testing it out. So the hope is that moving forward, we'll have more and more information to confirm it's a useful tool, and that then we can embed that into clinical practice around the globe. So I might stop there and happy to take some questions.
Yeah, so that's so interesting because we know from what we hear from people who have celiac disease or parents of children who have celiac disease that the big challenges around getting diagnosed are two things. It's eating gluten again and having the endoscopy. So this kind of is like a 1-2 punch. I like the way you describe the test as a gluten challenge in a test tube. I think that's such a good way to put it. Although it does take a moment of realizing it's a really different way of testing for and diagnosing celiac disease. Going forward, do you think it's just a matter of needing to test it in more people, or have your studies run into any little glitches or things that need to be worked out along the way? It's just that you need to see it happen in larger study populations?
Yeah, that's a great question, Amy. I think in these big studies, we need to make sure we're getting a good representative sample of people who would represent what we might see in the general community. And what we need to study more of are people who have some of the less common gene types associated with celiac disease, like DQ8, and confirm that the test works well in those specific gene types, as opposed to the more common HLA DQ2.5, which is seen in about 90% of people with celiac disease. We also need to confirm the test works well in children, and those tests are underway. And really, I mean, apart from those things, it's sort of looking very promising. So I guess it's next is publishing the data, which we're hoping to do. We're presenting it at the upcoming Digestive Disease Week meeting in May in Washington, DC, and then hoping to get more groups around the world adopting the technology to take it on. The beauty of this approach is it's not particularly hard to do. You just need a particular machine that can measure the interleukin-2 in the blood sample after it's mixed with the gluten peptides the next day, and they're readily available. So it's something that we hope that simple pathology services can provide.
That's great. We hear from a lot of people who have gone on a gluten-free diet before getting diagnosed, sometimes at the recommendation of their doctor, sometimes not. So is this, it kind of seems like this is a holy grail for the people who have been on a gluten-free diet, feel better, and feel so much better that they really don't want to go back and eat gluten for 6 to 8 weeks in order to get, properly diagnosed.
Right. Yes, it's absolutely a big challenge. And I've seen this for, over 20 years, where people, for often, good reasons that they're feeling so unwell, they try a gluten-free diet and start to feel better. And understandably, when we say, well, look, we can't properly test you for celiac disease, but it is important that you do get tested, they just don't want to go back on gluten. Or they do try it for a while and then get so feel so unwell that they stop it. Gluten challenges is actually something that I've done a lot of over the last 20 years, because that's part of our research. And whilst it's not something that we would voluntarily want people with celiac disease to do, obviously quite the opposite, for research, gluten challenge can be very informative. It can give us a lot of information about this kind of immune responses and other things that are happening in their bodies. So we've developed quite a bit of information from gluten challenges. And in my patients, when they have gone gluten-free beforehand, I still do gluten challenges, but I've developed different ways to try to make it a little bit more tolerated. And there's things like introducing gluten at a small amount and slowly grading up, often using low FODMAP versions of gluten. So instead of just eating lots of bread and pasta, which is likely to trigger symptoms, we might give some low FODMAP versions of that. I'm not sure how widely available low FODMAP versions are in the US, but in Australia, it's quite a big thing. And we know that FODMAPs are these fermentable carbohydrates in wheat products. It's not gluten, but there are other fermentable components. They're called fructans in wheat that often trigger bloating or diarrhea or tummy cramps in a lot of people. And so by reducing the FODMAP content in the gluten challenge, that helps a lot of people tolerate the gluten challenge better. So there's little tips and tricks that I use and that colleagues use to get people to stick with the gluten challenge. And we do sort of encourage them to push through it. It is very unpleasant, particularly initially, but it is such an important maneuver. But we hope that one day it will not be necessary at all if a person's gone gluten-free due to our test. Obviously, the other thing that we haven't mentioned that can be useful is the HLA gene test for celiac disease. In Australia, this is widely available and covered on our Medicare, but I know it's different in the US. But if a person has the HLA gene test for celiac disease and it is negative with celiac disease, then the likelihood of celiac disease is extremely low. It's probably less than 1%. So that's another way you can rule out celiac disease without having to do a gluten challenge. The problem is, if you look at the US population, just generally, there's a high proportion, probably 30 to 40% that have these genes anyway. So a positive test doesn't equal celiac disease. Only a negative test helps to rule it out. But anyway, that's another tool that we use. And like I said, in the future, hopefully our blood test will make both that and the gluten challenge redundant.
So you can almost anticipate what my next question is going to be. And also, we had asked people who were registering to participate in the town hall to ask us the questions that were on their mind. And so this one seems like a very natural next one. What is the estimated timing related to the new test being available? And how
Yeah, that's
easy
a
or
great question. It's
difficult
the hardest question. Hardest question to
Yes.
answer because there's
And
lots of.
she also asks how easy or and this might be, both of them are not easy to answer, but how easy or difficult would it be to get a new test adopted, particularly because we have this protocol and all kinds of guidelines that are based on the consuming gluten, the TTG test, followed by the endoscopy and biopsy. So.
Right. Yeah. Well, so great questions. We are now partnering with a industry collaborator who is keen to advance this test into the clinic. So the good news is, so we, as a researcher and a gastroenterologist, I don't have expertise taking a blood test through to the clinic. I need sort of experts who are used to doing that kind of thing and have the ability to advance it. So the good news is that they're involved and they're keen to sort of take this test forward so that you can get all the relevant approvals to embed this into clinical practice. And they have links in the US, and there's different ways that this could be done, but they're already looking at that approach. So the hope is if the data that we will be publishing this year, and then other groups hopefully will follow in the next year or two, I would anticipate this is something that could be embedded fairly quickly, like I'm talking the 3 to 5 year mark. But again, that's a very big estimation. But this is the data is already very promising. We're getting international data from other groups outside of Australians with celiac. So we already have data from Boston, for example, Boston Children's Hospital, and we're getting data from Colorado and a few other sites. But yes, the hope is, I would love to see this within the next 5 years out there. In terms of, I think the other question, Amy, was how would this then get embedded into clinical practice? And I think that we know that medicine is slow and adoption of new technology is slow. And I think doctors need a lot of evidence to confirm and reassure them that the test is working well and it's accurate and providing the right information. So I think that once groups take this on and replicate the findings, the hope is that this will sort of slowly kind of roll out to clinicians. And, it's probably 5 to 10 years for guidelines to start to be tweaked and updated. But I think that as the body of evidence mounts, then practice will change as well.
Seems reasonable.
One of the issues we know with clinical trials right now is that you almost always have to have a biopsy diagnosed celiac disease in order to participate in a clinical trial. Do you think as this gets accepted into clinical practice that it could also start replacing that requirement for clinical trials?
Yeah, that's a great question, Kate. Well, the answer is, I think, yes, because we know this already. So I'm involved in a lot of clinical trials for new drugs for celiac disease. And I know that's not a topic for today, and perhaps for another time. And the inclusion criteria, the type of people we let into those trials, generally always state that the person has to have biopsy-proven celiac disease. But what we've seen in the recent years is that many drug developers are also happy to accept people diagnosed through these ESPGHAN guidelines, the so-called serology guidelines that I spoke about before for children. So if a child has been diagnosed with those blood-based guidelines according to the appropriate protocol, and then they've grown up and now they're over 18 and they're available for clinical trials of celiac medication, then they're eligible as well. So the field is accepting new ways to diagnose celiac disease as being kind of like the truth. And so again, if there's good data to support this novel approach that we're developing, then then that should be accepted as well.
So there is some recent research that suggests that the TTG IGA tests may not be as accurate a method of diagnosing celiac disease in Black populations. And there is more work needed to understand why that might possibly be the case. What kind of factors contribute to that in terms of ethnicity and genetics and things like that. But the question is, how are you making sure that the new test is accurate in people of varying racial and ethnic backgrounds?
Yeah, a really important question. And I think this comes down to this whole need to get other groups to validate it in their local populations and get as broad a population that represents the community as possible. And that's why, for example, here in Australia, we're trying to get the test and test a range of people with different genetic backgrounds or different ethnicities, just to make sure it is not going to give a false positive result in people who don't have celiac, but it will give a positive result in people who do have celiac. So it's really ensuring that we have the good collaborations around the globe and that there's a plan to really be inclusive in these studies.
We could probably talk about this subject for the entire hour, but in order to get to everything that we do want to cover today, I thought we might move on to the ever interesting subject of oats. And Jason, if you want to tell us a little bit about the work that you've done in that area.
Right. Okay, sure. So oats has been somewhat controversial as part of the gluten-free diet around the globe. And that's because a lot of the early studies looking at the safety of oats suggested that perhaps oats weren't safe for people with celiac disease. But what we've come to realize is that there's a few factors going on here. Most commercial brands of oats often contain large amounts of wheat, rye, or barley gluten. In other words, they're contaminated with sources of gluten. And it's very possible a lot of the early studies looking at oats were actually reflecting the fact that there was other forms of gluten in the oats products, and the oats themselves were not harmful. So when you look at the studies assessing people who have pure contamination-free oats, and in the US, these are called gluten-free oats. When you look at the studies on gluten-free oats, most are very reassuring that people with celiac disease can safely have them. However, there are a few exceptions to those studies suggesting that perhaps a small percentage of people with celiac disease may have untoward effects to oats, either bad symptoms or immune responses or even small bowel damage. So we sought to try to address this issue. In Australia and New Zealand, oats have been excluded from the gluten-free diet. So it's a different situation to the US. And so here in Australia, everyone with celiac disease are very keen to eat oats, but they're not officially allowed to at the moment. In our research, we were trying to understand, well, what's really happening in people when they do consume pure oats. And when you look at pure oats, pure oats contains a protein called avenin. This avenin protein is a cousin to the gluten found in wheat, rye, and barley. So they're not siblings, they're not closely related. Maybe I should say distant cousin, because most of the oat avenin looks very safe for people with celiac disease when you look up the breakdown of it. However, there are some sections of oat avenin that look very similar to the gluten found in barley. And so there is the theoretical possibility that those parts of the pure oats could actually trigger a response in some people with celiac disease. We fed people with celiac disease purified oats. So we got oats that were made in a contamination-free field. So we use what's called the purity protocol. which makes sure that there's no contamination of the oats. And we had very clever people isolate out that oat protein, the avenine, so that we could feed it to people at different doses and give them quite large doses because we wanted to test its safety. And we showed, rather surprisingly, that a sizable percentage of people with celiac disease were responding to that oat avenine protein with either the immune response, that interleukin-2 response I measured before, that was a sign that their T cells were getting activated. And some indeed actually had symptoms such as diarrhea, abdominal pain, or vomiting. Now, sometimes when people eat just off-the-shelf oats, they can feel tummy aches and symptoms. And in some cases, that's because oats contains a lot of fiber, which is a good thing, of course. So the beauty of our research was by taking away all of the fiber and just studying the protein, we know that those reactions were truly to the oats avenine and not caused by too much fiber that we were feeding people, for example. And we then went on to feed this protein to people for longer periods, like 6 weeks, and then biopsy them before and after. And we showed that people did not get the damage in their guts. There were some people who dropped out of the study because of symptoms. And when we assessed those people, they had a very strong immune response that was more similar to wheat than those people who were able to tolerate the oat avenine for longer and who did not have damage. And so we're talking about approximately 5% of the population we studied were like that. So this is, a small population of people with celiac disease that do have a reaction to oats. And there, we would say that those are the people that shouldn't be eating oats. But on the whole, most people tolerated it very well, enjoyed it, and had no gut harm whatsoever. So I think oats are a fantastic cereal in general in terms of its nutritional properties. We all know the gluten-free diet is very restrictive. And we also know from a lot of studies that, that there is higher rates of metabolic syndrome and cardiovascular disease in people. And in my practice, I frequently see women aged, let's say, between 30 to 50, whose one of their big issues is weight gain and metabolic syndrome or fatty liver disease. It's really problematic. And so the addition of oats, which is very good at countering some of those effects, at controlling weight, reducing post-meal blood sugar levels. So it's great in the diabetes situation, good for cholesterol management. It's a really nutritious cereal. So it's something that I still would encourage people to have as part of their balanced diet with their dietitian. And not be fearful. But it's worth bearing in mind that those people who do react adversely to oats, it's not in their head, they're not making it up, it's a very real thing. And for those people, they should avoid oats. So I've been working with several groups now, including in the US and Europe, to try to come up with more consensus guidelines around this. Because at the moment in the US, there's different practices. Oats tends to be allowed in the gluten-free diet, but most guidelines, like the American College of Gastroenterology, do recommend careful follow-up of those people. So that would involve medical review to make sure the person has good nutritional value, that their celiac disease is under good control. And if that's the case and the person's enjoying the oats, I would encourage them to continue it and continue to enjoy it. So definitely don't want to cause alarm with this research, but I think it does tell us that there's a small population who do react and that we need to, moving forward, protect those people, allow them to have informed choice about not having oats. And I think this comes to broader issues around food labeling and ensuring that everyone gets enough information to make informed decisions about what they're putting in their mouth. So I might stop there. Happy to take some questions.
Sure. So the absence of what I'll call intestinal damage was important in this study. And is that because that was the key to distinguishing whether this was a celiac disease related issue or something separate for some small group of people that was specifically related to oats?
Yeah, that's a great question, Amy. I think really, as gastroenterologists looking after people with celiac disease, we worry and we focus in on the person's small intestine because, at least to date, we know that healing of the small bowel is important to achieve the best outcomes of, improving symptoms, but also improving bone density and reducing the risk of longer term complications. It's in the people who have the persistent small bowel inflammation, whether they're not following the gluten-free diet adequately enough, or they've got conditions like refractory celiac. They're the group that tend to have higher rates of complications. So um, for gastroenterologists like myself, I like to see that something isn't causing harm to the bowel. I want the bowel to remain healthy. And so this was an important way for us to confirm that the oats that were being fed to people were not causing harm. And so it was reassuring. And interestingly, some people actually had an improvement in their small bowel lining after having the pure oats. So it's just a way of confirming safety.
Yeah, I know in the US that a lot of dietitians with expertise in celiac disease are, like you, a fan of including the gluten-free oats in a healthy gluten-free diet.
So you said that people with celiac disease are probably sensitive to oats because there's part of that protein that could mimic the protein in barley. Is there any reason to think that other people are also sensitive to oats who don't have celiac disease but are reacting to that specific protein? Or would you think this is limited to people with celiac disease?
Yeah, that's a good question. You have to have T cells that react to that part of the avenue, and that's really only it's under 10% of people with celiac disease who react to that. Now, those particular sequences are very gluten-like, so they have proline and glutamine, these sort of amino acids that typically people with celiac disease, their immune systems react to. So I think it's very specific for celiac disease. It's not something that other people without celiac would have T cells reacting to. The one potential way, obviously people will often say, well, how do I know if I'm in that group? I eat oats, I think I'm okay. Like, how can I tell? And I can say that the people who reacted, there's no doubt that they know that they're going to react, even though we gave very small amounts of Avenin and they reacted. These are people who, when they tried just standard serves of normal oats, were also very symptomatic. So it's not a trivial reaction. These people do have quite sustained abdominal symptoms like vomiting or nausea or diarrhea that don't settle even with ongoing exposure. Now, if a person tries some oats, they might go, oh, you're a bit bloated today. That oats do have a really good amount of fiber, so maybe it could be that. And I would encourage people to push through that for a little longer. Clearly, if they're unwell, stop and speak to their doctor. But if they've had it and initially a bit of bloating, but they keep eating the oats and then they're enjoying it and it's not causing issues, then follow up with their doctor and just make sure that everything's going fine on their blood work and everything. That's great. Don't get too stressed about it. Here in Australia at the moment, because we are shifting from not allowing oats to allowing oats, we're a little bit more cautious. So we do include a gastroscopy and biopsy as part of that workup, so that people will have oats, introduce it for 3 months, and then have a gastroscopy and biopsy to confirm that their bowel is still looking fantastic. And that's another way we can be sure that it's fine. Now, whether you need that or not in the US, that's probably will be variable practices, but do speak to your doctor about whether that's worthwhile or not. Of course, if you're going to have one anyway, just to check up on the celiac disease, then that would be a good time anyway to see that everything's going well.
Mm-hmm. So we had a question from Crystal, who is a member of our audience. and she wanted to know whether a newly diagnosed celiac disease patient needs to wait a certain amount of time before they reintroduce oats into their diet.
Oh, that's a great question. There's a lot of discussion in group by groups about the best way to introduce oats. Some groups are very happy to introduce it from the start and then see how a person goes. Some guidelines actually recommend waiting until a person has established themselves on a stricter gluten-free diet without oats, and that could be waiting a year or two, or demonstrating healing. I don't think we have the answer to that, and I think that different doctors will have different approaches. I think the key is that whenever you do introduce it, that your team are aware, your dietitian and medical team are aware, and that they just keep an eye on you. So I'm actually we've got a study in Australia now that is following on from our previous research to really look at that angle, because there's a lot of questions about, can I start it straight away or should I wait? And so we've got a study looking at different ways of giving oats and then following them up to see if there's any difference. To be honest, I think because it's likely to be tolerated by the majority of people, if it's started even up at diagnosis, in most cases that will be fine. But I do recommend that there's that medical follow-up to make sure that things are going okay. And, people might feel well, but it is still important to check their nutrients, their celiac antibodies, and ideally have a look at their bowel at some stage as well with a gastroscopy.
Question in the chat from someone who said, in the US, there is some concern that purity oats are not really pure. Is this a valid concern? And is this concern the same in other countries?
Yes, so there's that's a really important question around how oats are produced, and the fact that most commercial brands of oats are not gluten-free in the sense that they're contaminated with other sources of gluten. And Tricia Thompson, a US dietitian, and others have done a lot of work in this space. And look, it is an important consideration, and we would not recommend people with celiac disease have any form of oats apart from those that have been called gluten contamination free or gluten free in the US, as they're allowed to be called. There are ways that to produce those particular oats, and this is the purity protocols that have been discussed, and there's different approaches utilized to generate those oats. Some involve fields that have been completely only dedicated to oats, or the machinery is only oats, and the fields are very closely reviewed for any contamination from stray grains of wheat growing in them, and there's several groups that utilize that approach. There are some groups, and I know of one in Australia that uses a different mechanical sorting method, which screens the grains as they're going along a conveyor belt and uses a laser that screens them, and then a little thing that shoots out and knocks any contaminated grain off the conveyor belt. That's a different approach. So there is some discussions around, well, what is a true purity protocol? These are ongoing discussions. I think it is important to try to get some standards around this, but I think for now, my understanding at least is that if it is saying gluten-free oats, that there is that assurance that it isn't contaminated and it has been tested, and you would have less than 20 parts per million of gluten contamination. So that should be fine. But I do think it is important for us to standardize the purity protocols.
Mm-hmm. So this is an interesting question that we received from Linda, and she's asking, is there a way to tell if oats are a problem if you don't have symptoms to gluten, so you're asymptomatic? How can you tell whether the same thing might not be true in relationship to oats?
Yeah, really, really good question. And for people who are asymptomatic with gluten exposure, we really rely on blood tests and biopsies to sort of gauge what's going on in the body. When I see my patients with celiac disease, the types of things I might perform include obviously taking a history, finding out how they're going, how they're feeling. And I'll do blood tests to look at their nutrients like iron and B12 and folate and vitamin D. And then I'll also check their celiac antibody levels Normal levels are reassuring, their diet's going okay. But we know that the celiac antibody levels are not a perfect indicator for how celiac disease is being treated. Of course, it's reassuring that when they go back to normal and when they remain positive, we want to make sure that we need to check for the presence of ongoing gluten exposure. But really, it comes down to a gastroscopy and small bowel biopsies to really understand how well the bowel is healed. There's a lot of research looking at what we call non-invasive markers to try to replace doing gastroscopies. I try not to do them too often in my patients. Really, I do them at diagnosis, and then I'll do them once again about 2 years later to follow up healing. But not everybody needs to have a gastroscopy if they're doing well. But in people who have no symptoms and they have concerns about how they're tracking, then that's really the best way to see what's going on with their bowel. So I think, if that person is tracking well, their bone density is good, their nutrients are good, then and their celiac antibodies are negative, in most cases, then that's reassuring. But if there's concern, then a gastroscopy and biopsy would be the next test to really consolidate that information and confirm everything's going well.
And so if that asymptomatic person had a sensitivity to oats, most likely they would be able to tell by symptoms. Like it would be
Absolutely,
odd
yes.
to be asymptomatic and sensitive to oats at the same time.
Yes, so it can,
Yeah.
that in our group, we did have some asymptomatic people to gluten, but they were symptomatic to the oats. So I think, though, that it is still a good point. Can you be asymptomatic to that oats protein, but could it still be causing harm? And I think this is the question we want to answer with our Australian study, where we're getting people on the oats and doing those long-term biopsies. The bottom line, again, though, it does seem to suggest that most people who are tolerating oats and not having adverse symptoms will not have any damage in their gut. They'll be fine. But again, I tend to be sort of conservative, and for my patients, I do like to check them, but it may be unnecessary.
Mm-hmm.
Well, that was a good discussion about oats. I hope everyone left with a little bit more of an understanding of what they should be doing. I think timing wise, we have our last topic, which is about adherence tests and measuring gluten in urine and stool. So do you want to talk a little bit about those?
Sure, Kate. Yes. So how do doctors follow up people with celiac disease, whether they're children or adults? And I kind of touched on that a moment ago. We might sort of say hello and ask a bit about how you're going. And then we might do the blood test to see what your nutrients are and also check your celiac antibodies. And we know that none of those approaches are particularly accurate at telling us whether a person's getting gluten in their diet or not. We can get a dietitian to review a patient, and that can be enormously valuable. But a dietitian can really only assess a person's knowledge of the gluten-free diet and their behavior. But what if they're accidentally getting gluten when they go down to the local restaurant? And we're not going to be able to tell that. And really, a gastroscopy will be able to tell us if the person's got ongoing damage. So that's useful. But again, it's not telling us when and how a person might be getting gluten, or if even gluten's the cause of those changes. So there's been a real need to monitor someone on a gluten-free diet to know if they're actually getting gluten or not. And the current tools that we have, like the blood tests, are just not perfect at all. So more recently, in the last few years, there's been this technology called the gluten immunogenic peptide tests, or GIP or GIP tests. And these GIP tests measure the presence of gluten fragments in the urine or stool. And these fragments or peptides are basically there in the urine or stool because the person's consumed some gluten. If you've not consumed gluten, you should not have any GIP in your stool or urine because it's just not coming to your body. In other words, if you can test for the presence of gluten in your urine or stool sample, we can say, well, you've actually had some gluten in the recent past. So these tests come in different formats. There's a stool test and a urine test. The stool test is thought to assess gluten that's happening, and it stays in the stool for a longer period, but we didn't really know how long. And the urine test is meant to test for the presence of urine over a shorter period of time, because as you can imagine, you clear out your urine a lot more frequently. And so these chip tests have created quite a lot of interest in the field about ways to simply monitor people on a gluten-free diet and check how well they're going. But we've done some research that we've published now looking at how well these kits perform. And we got people on a gluten-free diet to eat a cookie that either had no gluten in it or it had a small amount of gluten, 50 milligrams. So that's very like 1/100th of a slice of bread, small amount of gluten, right up to 1 gram of gluten, which is a much more decent amount of gluten. And so people had one cookie, they didn't know the dose of gluten in it. And then we collected their stool before, but also after that for a week. And we used these tests to measure it. And these tests were amazingly sensitive. So it detected all of the cases of gluten exposure when they had 250 milligrams or more. And it detected 70% of the cases when they had 50 milligrams or more. And these are very tiny amounts of gluten. So this was much better. We asked people, do you think you had gluten in the cookie? No one got it right. People often said yes, and they didn't. And people often said no, and they did. And people, except at the 1 gram level, there was more symptoms, and people then were able to predict. But even then, the presence of symptoms were not very useful to predict if a person had gluten. A lot of people complained of symptoms after having a cookie that had no gluten in it. And people's symptoms did not correlate with whether they had gluten or not. So in other words, whilst, I believe my patients, when they have symptoms, they're very real symptoms, but often when they attribute it to gluten, it's not always the case. It could be because that the meal was too rich, or, maybe they got a bit of food poisoning, or maybe it's FODMAPs in the food causing a bit of bloating. So what this tells us is that people's symptoms, even though they're very real, aren't always linked to gluten, and it's not a good way to determine how the diet's going. Nobody had increases in celiac antibodies in this study because celiac antibodies are not sensitive to single dose of gluten exposure. The only test that was really accurate was testing the stool for the presence of the gluten. So this chip test performed very well. And even after a gram of gluten, it stayed positive for close to a week. So it can be very useful over a period of time. And an example of how these tests may be used will be you do the test maybe weekly for a couple of weeks, and it'll give you a sense for whether that person's having gluten or not. And this may be particularly useful for those people who feel that they're not getting better on a gluten-free diet, or who are still having small bowel damage despite being gluten-free for over 12 months. So the tool may be useful to see whether a person is actually getting gluten without them necessarily knowing about it, because they're not getting symptoms, or they're getting symptoms all the time, and it's hard to make the link. So the urine assay it is less useful for those prolonged periods because it only appears in a shorter time frame, but maybe it's useful after a person goes home after a meal and is on the toilet for a couple of hours and feels awful, and wants to know, well, was that gluten or was it food poisoning, and that they can test their urine to test for the presence of gluten. So I think that these tools are very promising. There's still some unanswered questions before we can say, yes, let's do it on everyone. And some of those questions include the fact that, well, it's a very sensitive test. What does a positive result mean? Is it always a bad thing? Because if a person has a positive result, maybe that level of gluten exposure is not enough to really be causing harm. So there's some studies now trying to link the presence of the gluten in the urine or stool with damage in the bowel. And some studies have shown an association and some have not. So I think we don't want to cause alarm. We want to in people with celiac disease, but we want to make it a useful tool that can help them on their journey following a gluten-free diet. And so how that is best done, I think we're still sort of starting to work out. But I think in the future, this may be a way to help support the follow-up of people, like, for example, children getting established on the diet. It's great. You don't have to do a blood test. You can just test their stool sample. And so there may be ways to sort of incorporate that into clinical care to just really give people the confidence that, yeah, look, I think I'm doing fine. Like, I've been tracking a lot of my patients who don't get proper healing. And sometimes we can actually track these spikes to when they've eaten out at certain places. And it can be quite a useful tool then to identify periods of gluten exposure that would otherwise go undetected. So I think still lots of questions, but a promising approach that may be useful for the care of people moving forward.
I am wondering about the use of, in particular, the stool test by patients themselves. First of all, I think people will be happier to do a urine test than they are to do a stool test. There's some reluctance there. But I just wondered if you have any, well, first of all, I guess the first question would be, is this something you see more as having an application for someone who's your physician who's treating you and helping you monitor your diet? Or is this something that you as a patient could use? And then the second part of that would be, do you have any sense of how accepting people are of using the tests? And I guess there's a third part, sorry for all these parts. I'm wondering a little bit about hypervigilance and
Yes.
what might happen in that regard, because we know that can be a problem in celiac disease. And I'm
Right.
sorry to
Yeah.
lump
All
all these
excellent
questions together.
questions. Yeah. Amazing questions, Amy. So let's jump to acceptance. Most of the studies have been in urine, and we've shown in our stool study it performs much more sensitively and effectively. But there's the pushback is just patient acceptance. And I think that varies a lot depending on where people are. Like in Australia, I think maybe where maybe there's maybe the less squeamish factor or something, but people actually had no issues at all collecting their stool into a little lunchbox and storing it for us in the freezer. And I know that's very off-putting to a lot of people, and it does make the appeal of that approach much less attractive. There are at-home kits available where people can actually do the kit, a bit like a COVID test or a pregnancy test at home on their urine, and you come up with a red line. The sensitivity of that approach is not as good as when you send the sample to the lab and they do it using their much more sensitive equipment to look at the changing colors of the band and everything. So at the moment, the at-home kits, we haven't had a lot of good supportive data to say that that's as good as the approach. It would be amazing, though, if it was, because that would give the power to the patient to then use it to monitor themselves. And I think that could be good. So right now, the at-home kits aren't performing as well. So that's important to bear in mind. And the stool kit does perform better than urine, but there is that patient acceptability issue. I think that there was the third part to your question. Oh, yes, hypervigilance is, I think it's a very legitimate question. We've seen that with, for example, the table-side testing tools that I'm sure you're familiar with what I'm referring to, where you can test your food, but you only put a little sample of food on, wait 10 minutes for a result to see if it has gluten, and then you have to test everything else on your plate. And I think that my approach, and I've been doing some work in Australia, more from a regulatory point of view, looking at food contamination in the hospitality industry, and really showing, at least in Australia, in Melbourne City, which is very gluten-free aware, just over like 1 in 11, was it 1 in 11 foods supposedly gluten-free when we sampled them through one of the health officers actually had gluten in it. So, cross-contamination when eating out is a real thing. So, that sort of argues that gluten exposure does happen. But I think it's really important that there's the hypervigilance isn't that people we fix that angle. Like, in other words, if people ask for gluten-free, that they get gluten-free. So we do all of that, and that hopefully will reduce the kind of hypervigilance that people have, because obviously there's an understandable fear, because people have been gluten when they're told, oh yeah, it's gluten-free, and so you can't trust anyone, and you can't, it's just very bad. And so I think if we can fix those things, then it doesn't fall on the person to have to test their own food and stuff, because I think that isn't healthy. And I think I understand why people might be anxious to do it, but I just don't think it's the way to live your life, testing all your food beforehand, or screening your urine and stuff, obsessively all the time. So I think, again, tools are useful if done for the right purpose and in the appropriate context, but we don't want to make people a slave to these sorts of things. They're meant to help people do it, inform people to follow a better gluten-free diet, but not make them anxious.
Right. I think a good follow-up question to this that came in is that can patients get their antibodies down to a true zero? And if you're staying at, your TTG antibodies are still coming up at below the level that indicates celiac disease, but they're still, 3, 4, they're really low. Is that a problem? Should patients be striving for zero, or should they, is that level okay?
Yeah. I've never seen a normal zero celiac antibody. No. So the answer is no, you never get it to zero. Even people without celiac disease will have transglutaminase antibodies at some level, but it will be below the cutoff. So really, the goal is getting it below the cutoff, but it's not feasible to really get it to zero. It just doesn't happen. So that's okay. Don't stress about that. And I suppose the other angle to this question is, also, don't stress too much about the celiac antibodies themselves. The trend down on a gluten-free diet is good to see, and that's important. But, sometimes people will come in and say, oh, my value was, 8 2 months ago, and now it's 15, and it's like, and they get very anxious about that. And we know that the celiac antibodies are a rough indicator only as to how the bowel's going. So it's really the big picture of how the person's going. And if necessary, if in doubt, a gastroscopy and small bowel biopsy is a much better way of knowing what's happening inside a person. And there are some people, a small proportion, who never normalize their antibodies, but they do get healing, complete healing of their small bowel. And in that case, that's great, because that's the goal, the healing of the bowel, not so much the normalization of antibodies. So I tell people, don't get too hung up on those figures. As long as the trend is coming down overall, as long as you're feeling well, your nutrients are good, your bone density is good, and ultimately your gut's healing up. That's the main thing.
Do we have any? I think we might sneak in one last question. Is there one last burning question we want to pull from the ones we didn't ask?
I think there's one more from the chat, and someone had written this in as well. And I kind of think the version that someone wrote in is a little bit funnier. And you've touched on this a little bit, but is it necessary to always have a follow-up endoscopy after 2 years if you're doing well on the diet? Or is that just a way for GIs to make money? Just much more applicable in the US, I think, than in Australia. But
yeah, no, that's a really good question. And oh, sorry, I thought that was my timer. And basically the answer is the field's evolving on that. And I think the answer is no, not everyone always needs a gastroscopy. And what we're doing, trying to be more clever now at identifying who does. And there are several algorithms that are being developed to say, okay, these are the people who are more likely to have damage, who need to be closely followed up. Those algorithms typically include, if a person has very severe damage at diagnosis, if a person's elderly at diagnosis, for example, and look, I mean, there's different cutoffs, whether it's diagnosed over the age of 60 or over 70 or something like that, but older age of diagnosis, if a person has persistent symptoms, and those sorts of factors are more likely to be associated with non-healing at the 2-year mark. So that's when we may want to have a look just to check on that. But the person who is, let's say you're diagnosed at 30, you go gluten-free, you're feeling well, your nutrients are good, your antibodies have come back to normal, your bone density is good, then the argument would be you don't need to have a gastroscopy. And I certainly give my patients the choice there. Some want it, some don't. And I'm happy as long as those other indices are fine. And increasingly, I think we're going to be a lot more judicious about the need for repeat gastroscopies, because as we've talked about, some people are being diagnosed by the antibody tests alone. They've not even had a gastroscopy. So I think we are shifting away from regular gastroscopies. Certainly in my patients who do have one and they've got good healing, I never repeat it. There's no need to have regular gastroscopies, unless, of course, a person develops issues down the track, like they become anemic or whatever, then that may need reinvestigation. But yes, regular gastroscopies is not indicated and really is something that I think should be minimized.
Well, I think that with all of the many things that you're looking into and all of the ways that the work that's going on at your research lab and around the world also, but points to, I think, a bright future for celiac disease patients in terms of improvements that they can see in a lot of different aspects of their lives. Be it how they can safely eat oats, how they can be diagnosed, how they can monitor how well they're doing on the diet instead of guessing. I think all of these things point to a bright future. And so I'm encouraged by this discussion and the work that you're doing, and also by your willingness to come back sometime in the not too distant future and talk about all the other amazing things that are going on. So thank you very much for joining us so early in your day, and for answering all of our questions so thoroughly. Much
Oh, thank you.
appreciated.
It's been a pleasure. And thank you for having me. I really enjoyed it.
All right. Thank you, everyone, also for joining us just before your dinner hour. And we'll let you know about upcoming town halls through all of our normal ways of getting in touch.